hand rub is very important before and after the examination. Listen to the examiner commands also. It will be written in the wall. What the patient's symptoms or complaints will be written in the wall. What to examine. You can get a clue from that also. Going and get Dr.Ibrahim. Without person, you can talk in the local language if examiner permits you. I am getting permission from him. First, always have a 10 seconds to have overall look at the patient. General build, you can have some clue. Just a 10 seconds get a clue. Obvious distension can be seen, scars can be seen. Have a look. Just take in 5 to 10 seconds to have an overall look at the patient.
17 fail.
And I am going to start from the hands. Yeah, kai katanga. I am going to look at the clubbing, cyanosis. Kai katanga. Palmar right thumb depitus contracture. Depitus contracture go like this. You can able to feel any contracture. Okay. I am going to see a flapping tremor. Yeah. Thank you. Flapping. No flapping tremor. Thank you. Thanks. And on the forearm, I am looking at the AV fistula. Just for AV fistula, go like this. Sometimes subtle fistula can be seen, but you can palpate better. And feel by the pulses in abdominal session for 15 seconds enough. Thanks again. Just for every step, just tell the patient what are going to see. Just I'm going to see your neck. That's all. I'm looking at his JV. Thanks again. Just thanks the patient in every step. Thanks. And I'm going to examine his lymph nodes. Each side, one side at a time. Don't palpate bilaterally. Okay, thank you. Just I'm going to I'm going from hand. I have started forearm, neck, and then going to the face, eyes, kannu paathukenga, mela parunga. Okay. Naaku neetunga. Naaku vechukenga. Now I'm going to see for icterus keela parunga. Thank you. Also I noted for the KF ring. Now I'm looking in the overall face, any abnormality in the faces, any perioral puffiness also, temporal wasting in case of CLD. I'm now examining the oral cavity. I'm seeing the oral hygiene, any mucosal bleed, gingival hyperplasia. Thank you. இப்போ நான் உங்கள் கை மட்டும் பார்த்துக்கோங்க சரிங்களா படுத்துக்கிறீங்களா கொஞ்சம் லைட்டாக In chest we have to look for gynecomastia and spider navy. Axilla we have to look for loss of axillary hair. Now abdominal examination proper. Page side vechunga. Hand by the side. Patient lying supine. We have to expose from the xiphisternum to the pubic symphysis. And inspection. I am looking for any distension, any scars, sinuses, any pulsation, visible peristalsis. I am going to palpate the patient. Before palpating, just to rub your hand to make it warm. Sometimes cold hands cause some contraction in the abdomen. I can start from the left iliac fossa, come anti-clockwise. First is superficial palpation. Within sorry. If patient says pain, don't repeat the same again. Thank you. Now I am going to palpate for the liver. Ask the patient to take a deep breath. Can go below upward or above downward. I am going from below upward. Check. Now I am palpating for the spleen from right iliac fossa. Okay. If If you are not getting any organs, you can make the patient left lateral and palpate for the spleen again. And the important thing, we forget to see the renal palpation. One hand under the abdomen, one hand above, just for look for volatility. One hand below, one above, look for volatility. Then if ascites is there, distillation is there, you can check for fluid thrill by keeping the hand. You can ask the examiner's help to help you, they can help you. Then you can check for fluid thrill. Then going for percussion. Yeah, na 30 tidal percussion for liver. Yes, thank you. And draw space augmentation 30 Thank you. And spleen percussion, you can check simultaneously with shifting dullness. I am checking for shifting dullness now. Here 30 wire mattum. இந்த போல ஐடா திரும்பிக்கிறீங்களா? ஓகே, ஐடா நல்லா திரும்பிக்கங்க இந்த போல ஐடா. Wait for 15 seconds. Simultaneously at the time look at the back also. And at the same time you can percuss for the spleen also. That Kazel method, Nixon method is there. Kazel method is percussion at the lowest anterior intercostal space. If percussion is there, chances of splenomegaly is there. Nixon method is percussing at the posterior axial line. If dullness is there, from the point of dullness you have to measure till the intercostal margin. Okay, thank you. Lastly, don't forget to auscultate the abdomen. Just touch பார்க்கிறேன். Mainly for the hepatic bruit, bowel sounds and renal artery bruit, 2 cm above and lateral to the umbilicus. For renal artery bruit, at the liver point to the liver, and at the left iliac fossa or right iliac fossa for the bowel sound you can auscultate. Thank you. And finally I am looking at his leg. Thanks. If time permits, I will auscultate for the RS. Well, because only 6 minutes is given. If time permits, I will look for, make him sit up, auscultate for the lungs for any effusion, any murmurs, I will auscultate for. Thanks. Don't forget to research the patient, and thanks again. Thank you.
Thank you, sir. Thank you so much. Now let's shift the actual patient. I want the candidate to go to the hot seat. Let's shift the actual patient. Please, sir. Okay.
Screen ready.
Hello, I'm Dr. Eshwar, one of the medical doctor. I'm here to examine your tummy. Is it all right for you? I'll start from the head end. Do you have any pain anywhere? Can I check your hands? Could you show your hands like this? Could you show your hands like this? Sorry. Put your hand. Show your hand like this. I'm going to check your pulse. Can I look at your eyes? Can you look down for me? Could you open your mouth? Yeah. Lift your tongue. Please say, show like this. Could you sit up for me? I'm going to check your limb class, okay? Okay. Do you lie down for me? Okay. Can I? Do you have any pain anywhere? Okay. I'm going to press your tummy, okay? Do you have any pain anywhere? Could you take deep breath in and out for me? Can I tap your abdomen? So can I do the percussion from the chest over the cloth? Okay. Do you have pain here? Okay. So, could you move her up? Take a deep breath in and out. Can hold it.
You have 1 minute remaining.
I'm going to press your legs, okay? Could you sit up for me? Take a deep breath in. Okay. On examination of this lady, I found she is thin built on general examination, and also she has a pallor and then icterus. She has mild pitting pedal edema of both limbs. On examination of her abdomen, on inspection, she has a abdomen is distended, and then on palpation, I found there is a spleen, which is she has a massive splenomegaly, and then I found she has a fluid trill also present. So putting this together, the differential would be the cirrhosis, and then second would be the any malignancies. So
What malignancy is this one?
hepatitis, probably a CM, lymphoma, cirrhosis. Cirrhosis with portal hypertension. And then second would be the in malignancies like CML and then lymphomas. And then third would be the chronic infections, malaria.
How are we going to approach this patient?
So first I would like to take a history from the patient regarding diet, travel, and then alcohol. And then about sexual history. After that, I would like to do a baseline investigation, like complete blood count to look for any anemia, and then liver function test to look for liver function test, and then third the PT-INR to know her coagulation status. And then after that, I would like to do a acetic fluid analysis to know for a SAT ratio. If it is low SAT, I will go for a high SAT. I will go for a serum proteins to look for any whether she has a low protein or not. If it is low protein, I will go for I'll go to look for a cause for a cirrhosis, like any NAFLD or alcoholic, and then
How would you confirm whether acid is there or not first? How to confirm?
yes, sir. So acetic analysis, and before that ultrasound abdomen and portal vein Doppler I will do for.
What other findings will note in ultrasound abdomen?
So there will be a altered ecotexture of the liver, sir.
Okay. And any other blood investigations?
Apart from that, I would like to do a ESR CRPs
And
and
okay, I see the question from you.
What is the most common causes of chronic liver disease, cirrhosis?
first would be if it is a male patient, alcoholic or a non-alcoholic fatty liver disease, and then viral markers I missed, viral markers. So hepatitis B and C, and then fine.
Marking பண்ணணும் மேம். did very well. The case was given as icterus pallor splenomegaly with ascites. So probably DD was decompensated chronic liver disease with ascites, portal hypertension, splenomegaly, and other DD was tropical splenomegaly related to malaria, and other DD was CML. All the three DDs the candidate has given properly, and for all the examination findings were given by you as correct. So the both examiners give mark for examination, physical science and DD satisfactory to you. And regarding patient welfare, you did well. Regarding judgment, you did well, but you needed prompting, and the investigation were not at the streamline. That was the thing. You were able to see, you were able to give all the answers, but you needed prompting. That was the main point. So we give a borderline for you in that point. Otherwise it was okay. You pass the station. Thank you.